Imagine a moment where everything neurologically goes sideways. A sudden collapse, maybe a catastrophic headache, a loss of function happening right before your eyes.
Yeah, the stakes are incredibly high.
So high. And the need for rapid, accurate assessment is just paramount. That's the critical arena we're stepping into today. We're going to unpack the initial evaluation and workup for patients facing these kinds of, well, acute neurological emergencies.
And for this deep dive, we're leaning on a really excellent review article. It's from Dr. Sarah Walster at the University of Washington and Dr. Nicholas J. Johnson.
Good source.
Yeah, their combined expertise provides a solid, structured framework for understanding how clinicians actually approach these really, really challenging situations.
Absolutely. And for you listening, think of this as getting the expert's playbook, but sort of condensed down.
Right.
We're extracting those crucial steps and considerations that guide specialists when someone presents with a sudden, serious neurological problem. Our mission, to equip you with the core understanding of how these emergencies are recognized, how the location of the problem is figured out, and how the urgent workup begins. We're talking about scenarios where acting quickly based on sound assessment can truly change a life.
It really can. So those very first moments when a patient presents are absolutely vital.
The golden hour or even minutes.
Exactly. The immediate priority is always ensuring basic survival. Establishing a clear airway, confirming they're breathing adequately, and supporting stable circulation and good perfusion.
Right, the familiar ABCs.
It's the ABCs, yeah, but with a very keen neurological lens applied.
Okay, let's dive into that airway piece then. We often hear this blanket statement. If someone's Glasgow Coma Scale, or GCS, that's a measure of consciousness, drops below 8, they automatically need a breathing tube, they need to be intubated. But the article actually introduces a really important nuance here. It suggests rigidly following that number might even be harmful sometimes.
That's a crucial point. The review really emphasizes looking for objective signs that the airway is truly compromised.
Okay, like what specifically?
Well, we're talking about things you can actually see and hear. Is there a visible obstruction? Is there a buildup of secretions the patient just can't clear? Are there abnormal breathing sounds like snoring or stridor?
Makes sense.
And while checking the gag reflex is common, just relying solely on that to decide about intubation is, well, it's debated.
Right.
However, if the patient has a weak or absent cough, that's definitely a major cause for concern. The key here is that a neurological event itself can directly impact these basic functions.
How so?
Well, for instance, a stroke affecting the swallowing muscles directly threatens the airway. So assessing that becomes neurologically crucial, not just a standard procedure.
That makes perfect sense. So it's not just about hitting a number, it's about actual evidence of a failing airway.
Precisely.
Now, how do doctors determine if someone is breathing well enough? Just counting breaths doesn't really tell the whole story, does it?
Not at all, no. They'll carefully observe the patient's breathing pattern. Is it shallow, labored? Are they using those accessory muscles in the neck and chest?
Oh.
They'll listen to the lungs for any abnormal sounds. And they use monitoring tools like waveform capnography.
Right, that's CO2 levels.
Exactly. It tells us how effectively CO2 is being eliminated, which is a direct indicator of ventilation quality right down at the alveolar level. And blood gas analysis gives precise measurements of oxygen and carbon dioxide in the blood.
And what if they suspect muscle weakness is the issue?
Well, if they suspect muscle weakness affecting breathing, they might also measure things like maximum inspiratory and expiratory pressure that assesses breathing muscle strength, and also vital capacity, the maximum air someone can exhale after a deep breath.
Right, getting a really comprehensive picture of respiratory function there.
Mm-hmm.
And then we move to circulation. We're talking blood pressure and heart rate, obviously. But the article points out those can sometimes be, well, deceptively normal, especially early on in shock.
That's true.
So what other signs are they looking for to assess how well blood is circulating?
They're also closely evaluating the patient's mental status. That's a key indicator of how well your brain is being perfused with blood.
Though that could be tricky if there's already a brain injury, I imagine.
Exactly. It can be challenging to interpret if there's a primary brain injury already. But other really important indicators include the temperature and color of the skin on their extremities, how quickly the tiny blood vessels in the nail beds refill with blood after pressure, that's capillary refill,
Okay.
and their urine output, which reflects overall organ perfusion.
This all sounds like an incredibly rapid assessment.
Yeah.
And often happening at the same time.
Right. Very much so. Simultaneous assessment and intervention.
And the article emphasizes a really crucial point. trying to get a baseline neurological exam before any intubation or heavy sedation, if at all possible.
Absolutely critical. Or if those interventions are unavoidable just to stabilize the patient, then using medications that are easily reversible or have minimal lingering effects on the neuro exam.
Good point.
And it's also vital to quickly check for those easily reversible conditions like hypoglycemia, low blood sugar, which can mimic a really wide array of neurological problems, confusions, seizures, you name it.
Okay, so the immediate threats to life are addressed,
Yeah.
stabilized. Now the focus shifts to figure out what exactly is going on neurologically.
Right.
The article explains this involves building a differential diagnosis, basically, a list of possible conditions based on the patient's history, and a thorough clinical examination. It's about identifying what the underlying problem is and where it's located along the neuraxis.
Exactly. The neuraxis being the central nervous system, brain, and spinal cord.
Right.
So the specific symptoms the patient presents with, how those symptoms have developed and progressed over time, these are absolutely key to understanding the nature of the illness.
And the exam helps pinpoint the location.
Yes, the particular neurological deficits observed during the examination help to pinpoint where along that central nervous system axis the brainstem, the cerebellum, the spinal cord, the problem is likely situated.
But the article makes it very clear that this initial evaluation is often anything but straightforward.
Oh, definitely not.
The history you get might be incomplete, it could even be misleading, or it might need constant checking and verification as more information becomes available.
Absolutely. And the patient's condition itself can change very, very rapidly. You have to constantly reassess and adjust the treatment plan.
Right.
And sometimes, critical information might come back from an urgent brain scan or a lab test, even before you've managed to piece together the complete history.
So you have to act on that immediately.
You have to be prepared to act on that more information immediately while still continuing to gather the full clinical picture. This is why, in neurocritical care, assessment and management often happen concurrently. They're just intertwined.
And neuroimaging, usually a CT scan of the head, sounds like it's often a very early and crucial step.
It is. It lets doctors quickly look for structural issues, like bleeding or swelling, that might need urgent intervention, especially if the patient's neurological status is rapidly declining.
And this all leads to the concept of must not miss neurocritical care emergencies.
Yes. The article even includes a table outlining these critical conditions.
Like what? Give us some examples.
Things like signs of dangerously increased pressure inside the skull after a traumatic brain injury, or a large vessel occlusion that's a blockage of a major artery in an acute ischemic stroke, or maybe a re-rupture of a brain aneurysm that has previously bled.
These are the scenarios where any delay in diagnosis and treatment could be, well, devastating.
Absolutely devastating consequences. Being able to recognize the most concerning signs and symptoms associated with each of these must-not-miss conditions is paramount for ensuring timely and effective medical care.
Now let's dig a little deeper into getting the patient's story, the medical history. The article acknowledges this can be really tough, especially with critically ill patients.
It really can be. Often the patients themselves are unable to speak or provide information.
So you have to rely on others.
You have to rely on family members, paramedics who brought them in, even past medical records if they're available quickly.
And those sources might not always be perfectly reliable.
Well, exactly. As the article points out, these other sources might have different levels of understanding about medical terms, or they themselves might be under a significant amount of stress, emotional duress,
Understandably.
which can inadvertently affect the accuracy or completeness of the information they provide. So clinicians need to be highly skilled at asking the right, focused questions, carefully interpreting what they hear, and then synthesizing all those details to build a coherent picture.
Sounds like it takes real experience.
It really requires both significant experience and a deep understanding of the various neurological diseases and how they present.
What are some of those key red flag symptoms, the things that, when you hear them, should immediately make you think this could be a neurological emergency?
Okay, the article lists several critical ones. A rapid or sudden decline in the patient's level of consciousness.
Right.
Any new onset of confusion or agitation, any new weakness or sensory loss affecting part of the body, new problems with speech or language comprehension.
Like trouble speaking or understanding.
Exactly. Sudden difficulties with balance or coordination, any new visual disturbances, the appearance of involuntary movements, and the sudden onset of a severe headache, especially if it's described as the worst headache of their life.
that classic phrase.
And importantly, in suspected stroke cases, establishing the time last seen well, the last time the patient was known to be without any of these new symptoms, is absolutely crucial for determining eligibility for certain time-sensitive treatments.
And there are also more subtle clues, aren't there?
Yeah.
The article mentions a table highlighting these subtle red flags.
Yes, these are signs and symptoms that might initially seem less alarming but can actually point to serious underlying neurological issues.
Like what, for instance?
For instance, experiencing dizziness or vertigo, that spinning sensation combined with double vision or what we call cross-neurological findings.
Cross-finding.
Yeah, like weakness on one side of the body along with facial droop on the opposite side. That combination could strongly suggest a problem within the brainstem.
Ah, okay.
Or, another example, the combination of positional headaches especially bad enough to wake someone up at night along with vital sign changes like high blood pressure, a slow heart rate, and irregular breathing.
Cushing's triad.
That's Cushing's triad, exactly. That should immediately raise suspicion for dangerously increased pressure inside the skull. The article even gives a case example, a patient with just dizziness after a car accident who turned out to have a cerebellar stroke.
Yeah.
Shows how subtle signs can be really significant.
Wow. So it's not just about the specific symptoms themselves, but also how they've developed over time. The article talks about onset, hyperacute, acute, subacute, chronic.
Exactly. The speed matters. It often provides important clues about the underlying disease process.
So hyperacute is fastest.
Hyperacute onset, yeah. Symptoms developing within seconds to minutes often suggests a vascular event like a stroke or a bleed.
Correct.
Acute onset, over hours to a few days, might point towards infections or inflammatory processes. Subacute, developing over weeks to months, could be a tumor or a slower inflammatory condition.
And chronic.
Chronic onset, symptoms evolving over many years. That's more typical of degenerative neurological conditions. But it's also important to remember that some slower growing problems, like maybe a benign brain tumor, can suddenly present with very acute and severe symptoms if, say, they suddenly start to bleed.
Right, a sudden change. And the way the symptoms evolve, stable, fluctuating, improving, worsening, episodic, that adds more pieces to the puzzle too.
Absolutely crucial information. And then, of course, a key part of the history taking is trying to figure out where the problem likely is. Is it central nervous system brain or spinal cord or peripheral nervous system, the nerves branching out?
And if it's CNS, trying to narrow down further.
Right. Can you narrow it down to a specific region like the cerebrum, the brainstem, the cerebellum, or the spinal cord itself?
Understanding the patient's past medical history is also absolutely vital, the article stresses.
Oh, definitely. Things like pre-existing cardiovascular risk factors, any prior history of strokes or seizures, previous neurosurgery, psychiatric conditions, autoimmune diseases, substance use history.
Medications too, I assume.
And all of their current medications, absolutely, especially things like blood thinners, anti-seizure drugs, or immunosuppressants.
What about hospital meds?
And in patients who are already hospitalized, it's crucial to know if they recently received any sedation or neuromuscular blocking agents, because those can significantly and temporarily alter the neuroexam finding.
Good point. And finally, the history plays a deeply important role in understanding the patient's overall goals of care and their baseline functional status. What were they like before this happened?
So critical. This information is vital for guiding those really difficult, sensitive decisions about life-sustaining treatments in these high-stakes situations.
It really is.
Having a clear understanding of what's important to the patient, what their prior wishes might have been, their functional abilities before the acute illness, it helps guide ethical and appropriate medical care during these incredibly critical moments.
Okay, so we've covered the critical steps of stabilizing the patient and then gathering their story through the history. Now, let's move on to the clinical neurological examination itself.
Right, the exam.
The article states the primary goal here is to identify specific patterns of neurological deficits that correspond to different levels and regions of the nervous system, and to actively look for those critical signs that indicate the need for immediate intervention, like increased brain pressure, stroke signs, seizures, infection, spinal cord compression, or impending respiratory failure from weakness.
Exactly. And there are some unique challenges that come with doing a neuroexam on patients in the neurocritical care setting.
Such as?
Well, often their level of consciousness is impaired, which means they can't fully cooperate. Their neurological findings can also change really rapidly, sometimes minute to minute.
Wow.
And there are often multiple confounding factors, making it tricky to interpret the findings: sedation effects, neuromuscular blockade from intubation, underlying metabolic issues, infections. Lots of things can affect brain function.
You mentioned neuromuscular blockade. If a patient has been given those paralyzing meds, how do doctors even assess their underlying neurological function?
Good question. They often use something called train of four monitoring. It involves applying a brief electrical stimulus to a peripheral nerve and watching the muscle twitches.
Okay.
If there's still significant blockade, they might try to reverse it if it's safe to get a more accurate neuroassessment, especially if decisions depend on it.
And if reversal isn't possible?
Then the neuroexam might have to be deferred or at least interpreted with those limitations firmly in mind.
And it's not solely focused on the brain and nerves, right? The article emphasizes a thorough head-to-toe examination is still important.
Absolutely essential, especially in patients with altered consciousness or spinal cord injuries,
Yeah.
because they might not be able to report other injuries or systemic symptoms.
Good point.
And it's also really important to be vigilant for potential non-neurological complications that can arise from the neurocritical care procedures and interventions themselves.
The article also touches on how the clinical examination can provide clues in differentiating between problems starting in the central nervous system versus the peripheral nervous system.
Yes, definitely. The presence of altered consciousness or changes in mental status, along with findings suggesting corticospinal tract involvement, those pathways controlling voluntary movement tend to point more towards a CNS issue.
Okay.
On the other hand, things like changes in muscle tone, reflexes, and the specific patterns of weakness can often help distinguish between upper motor neuron problems, starting in the CNS, and lower motor neuron problems affecting peripheral nerves.
But it's not always clear-cut.
Not always. It's really important to remember that both CNS and PNS pathologies can sometimes coexist in the same patient. And occasionally, conditions primarily affecting one system can even mimic the presentation of a problem in the other. The article gives examples like Guillain-Barré syndrome with cranial nerve involvement looking like a brainstem stroke sometimes,
Right?
or an acute spinal cord issue initially presenting with lost reflexes, mimicking Guillain-Barré.
Interesting overlaps. Let's zoom in now on the central nervous system examination, starting with patients who have an acute brain injury. The article places a strong emphasis on looking for clinical signs of elevated intracranial pressure, ICP, and the potential for brain herniation.
This is absolutely critical. Increased pressure inside the skull can lead to herniation, where brain tissue gets squeezed and displaced. That often causes irreversible, life-threatening damage.
Scary stuff.
The article refers to a figure showing the different herniation syndromes. Clinicians are trained to recognize specific patterns, neurodeficits, changes in pupils, vital sign changes that strongly suggest herniation is happening.
What else are they looking for in acute brain injury?
Well, besides ICP signs, they'll also be carefully assessing for any signs of stroke syndromes, paying close attention to findings suggesting problems in the brainstem or cerebellum specifically.
And seizures?
And they'll be vigilant for any subtle clinical signs suggesting seizures, even non-convulsive ones. Things like a Britain tongue, incontinence, subtle eye deviations, repetitive fluttering or chewing.
Subtle signs are key.
Very key. They'll also evaluate for meningitis neck stiffness photophobia or other signs hinting at a CNS infection.
And the way they conduct this exam is really tailored to the patient's level of consciousness, right?
Oh.
Starting with assessing wakefulness and awareness.
Precisely. They'll begin by trying to talk to the patient, then maybe gentle tactile stimulation, and, if needed, carefully controlled painful stimuli to see the response.
But you have to rule out other causes first.
Absolutely. Before concluding someone has a true disorder of consciousness, you must rule out reversible causes, drug intoxication, severe metabolic issues, and consider coma mimics, like locked-in syndrome, where the patient looks unresponsive but is actually aware.
For patients who are truly comatose, unresponsive, what are the key exam components?
Primarily, they're looking at the patient's baseline eye position and any spontaneous eye movements. These can give clues about the injury location. They're also very carefully assessing brainstem reflexes, blink, pupils, corneal, oculocephalic, Gall's eyes, oculovestibular, cold calorics, gag, cough. The presence, absence, quality of these tells you a lot about brainstem integrity.
And motor responses.
Finally, yes, observing motor responses to those noxious stimuli. The specific way a patient moves, withdrawing, flexing, extending in characteristic ways like decorticate or decerebrate posturing, gives significant clues about the level and extent of brain dysfunction.
The article also mentions the significance of any abnormal movements observed. How do clinicians figure out if they're important?
They carefully analyze the movement characteristics: regular or jerky, localized or widespread, which body parts, frequency, amplitude, triggered or spontaneous, at rest or during movement,
Lots to consider.
and any associated findings like changes in consciousness or eye movements happening at the same time raise suspicion for seizures. But distinguishing subtle seizures from other movements in critically ill patients can be really hard.
Which is where EEG comes in.
Exactly, which is why electroencephalography, EEG monitoring, often plays a crucial role in diagnosing or ruling out electrical seizure activity.
And in the most severe, devastating cases of brain injury, the concept of brain death can come up. The article briefly touches on this.
Yes, it emphasizes that before even considering a formal brain death evaluation, a very strict set of clinical prerequisites must be met.
Like what?
The patient's history, the established cause of the injury, the brain imaging findings, they all have to consistently point to a permanent, catastrophic injury of the entire brain. And any potentially reversible factors mimicking brain death, certain drugs, metabolic issues, severe hypothermia must be completely ruled out first.
Okay, moving on to the examination of someone with a suspected acute spinal cord injury. The focus shifts to understanding the level and the type of injury.
Right. They will meticulously assess both motor function moving different muscle groups and sensory function feeling light touch, pinprick, temperature in various parts of the body.
And rectal tone.
The presence or absence of rectal tone checked during a rectal exam is a key early sign of spinal cord involvement. Autonomic dysfunction, problems with blood pressure, heart rate, bowel bladder control also provides important clues about the severity and level of the injury.
What about reflexes?
Well, while you might expect increased tone and reflexes below the injury level eventually, there's often an initial period right after the injury called spinal shock with a temporary loss of tone and reflexes.
And injuries higher up the cord, in the neck, pose specific risks.
Absolutely. Lesions at C5, the fifth cervical vertebra and above, can weaken or paralyze the diaphragm and other breathing muscles, potentially requiring immediate mechanical ventilation.
And blood pressure.
Injuries at or above T6, the sixth thoracic vertebra, can disrupt the sympathetic nervous system, leading to vasodilation, a drop in blood pressure, and the heart being unable to speed up properly.
Now, let's shift our attention to the peripheral nervous system conditions, like Guillain-Barré syndrome and myasthenia gravis. The article highlights the primary concern is often the potential for respiratory failure due to muscle weakness.
That is indeed the main focus. Clinicians will actively look for clinical signs of respiratory distress. Rapid breathing, increased effort, using accessory muscles, sweating, abnormal breathing patterns.
And they use objective measurements, too.
Yes, like vital capacity, max air exhaled, and maximum inspiratory-expiratory pressures to quantify respiratory muscle strength. There's even a clinical guide called the 20-30-40 rule, specific values for VC, inspiratory force, oxygen levels that can help guide decisions about intubation.
Any simple bedside tests?
Yeah, there's the single breath count test, counting as high as possible on one breath, which gives a quick indication of respiratory mechanics.
But normal blood gas doesn't rule out trouble.
No, the article rightly cautions that a seemingly normal blood gas early on does not always rule out impending respiratory failure in these neuromuscular conditions.
The article mentions a scoring system for Guillain-Barré to predict ventilation risk.
Yes, the Erasmus-Guillain-Barré syndrome respiratory insufficiency score. It considers factors like time from weakness onset to admission, facial or bulbar muscle weakness, and limb strength.
What are other warning signs for needing ventilation in GBS?
Other early signs might include inability to stand, a weak cough, or inability to lift elbows or head off the bed. And patients with significant facial or swallowing weakness need particularly close monitoring.
What about in myasthenia gravis? The symptoms there can fluctuate a lot.
Exactly, because the weakness in myasthenia can be so variable, just relying on static respiratory measures at one time point might not be enough.
So you need ongoing assessment.
Clinicians need to closely monitor overall muscle strength, how easily they fatigue with repetitive movements, and any developing eye movement or swallowing problems. Progressive fatigue, worsening neck weakness, voice change is all red flags for impending respiratory failure in myasthenia.
And swallowing is a big issue.
Yes, significant swallowing difficulties can cause problems managing secretions, increase aspiration risk, and sometimes the meds used for myasthenia can even worsen bulbar symptoms. Needs very careful attention.
Throughout all this initial evaluation and examination, the ability to detect any signs of neurological deterioration is absolutely crucial. The article really emphasizes this.
It is paramount. Patients in neurocritical care are at risk for secondary complications leading to worsening sudden ICP spikes, reduced brain blood flow, prolonged seizures, respiratory failure, hemodynamic instability.
And often the first sign is a change in the exam.
Often, subtle changes in the neurological examination are the very first and most sensitive indicator that something is going wrong and needs immediate attention.
So frequent and careful neurological monitoring is key. But the article also brings up balancing that with avoiding causing delirium or agitation.
That's a really important consideration in the ICU. Close monitoring is essential, but you have to be mindful of the patient's comfort and avoid unnecessary disturbances that could contribute to delirium or agitation.
And if the clinical exam is limited, say by sedation.
Right. When the clinical neuroexam is significantly limited, then additional neuromonitoring tools become necessary: serial brain imaging, continuous EEG, maybe invasive or non-invasive ICP monitoring to get crucial information.
The article also discusses using various clinical and radiographic scales and scores. We see these everywhere in medicine. What's their specific role here?
They serve several important purposes: objectively assessing initial severity, standardizing tracking of changes over time, sometimes helping guide treatment decisions, and some can even provide prognostic information.
Like the GCS we mentioned.
Like the GCS for consciousness, or specific stroke scales like the NIH stroke scale to quantify severity and track changes. There are also radiographic scores for quantifying injury on imaging.
But the article also offers a really important caution about relying too heavily on just the numbers.
Exactly. These scales are valuable tools, but must always be interpreted carefully within the broader clinical context, considering confounders. For instance, a patient with stroke-related aphasia might get a lower verbal GCS score that doesn't reflect their true consciousness. Or ICH scores need context about the bleed's location.
So adjuncts, not replacements for clinical judgment.
Precisely. Always use them alongside a detailed neuroexam, imaging review, and the overall clinical picture, never as a substitute for thorough clinical judgment.
Let's move on to the crucial role of imaging studies. The article emphasizes they're essential for identifying underlying structural lesions causing symptoms. And CT scans are usually first line for acute brain injury.
Yes, CT is often the initial choice. It's fast, widely available, and reliably identifies most emergent structural problems: bleeds, large strokes, hydrocephalus, skull fractures, and trauma.
And there's a structured way to review them.
Yes. The article outlines looking at different image windows for brain, blood, bone, checking for midline shift indicating mass effect, and systematically searching for the 4 H's: hyperdensity bleed, hypodensity atom stroke, hydrocephalus, and herniation.
Okay. And when is a CT angiogram, a CTA, typically indicated?
A CTA, using contrast dye to see blood vessels, is usually needed if you suspect a vascular problem, a clot blocking an artery in stroke, vessel narrowing, ruptured aneurysm, or vessel damage after trauma.
Especially if the exam is limited.
Yes. In patients with altered consciousness where a reliable exam isn't possible, a CTA should often be done early to quickly rule out critical vascular issues needing immediate intervention. The CTA findings then guide whether more invasive procedures like catheter angiography are needed.
What about CT perfusion, CTP imaging, often mentioned for acute stroke?
CT perfusion can provide info about blood flow. It helps differentiate the irreversibly damaged stroke core from the surrounding penumbra, at risk but potentially salvageable tissue.
So it helps guide therapy.
Yes. It can be very helpful in deciding who might benefit from advanced therapies like mechanical thrombectomy. However, the article notes CTP results need cautious interpretation in certain situations, like significant heart disease or pre-existing carotid blockages, which can affect accuracy.
And MRI, it gives more detail, but isn't usually first line in emergencies.
Correct. While MRI offers much greater detail, better for small strokes, early ischemia, brainstem, cerebellar spinal cord issues, it's usually not first line in a true emergency.
Why not?
Mainly because MRI takes longer and isn't as universally available 24/7. In acute situations, a faster CT or CTA provides the critical info for initial decisions. MRI is more often used in the subacute phase after stabilization to investigate further or look for things CT doesn't show well.
For suspected acute spinal cord injuries, what's the imaging approach?
In trauma, the first priority is clinical assessment for instability. If neurodeficits suggest spinal cord injury, a CT of the relevant spine section, usually cervical, is done first to look for fractures or cord compression.
An MRI later.
If the CT shows a significant issue or clinical suspicion remains high despite a normal CT, then an MRI might be done for more detail on cord damage, ligaments, discs. For non-traumatic spinal issues like myelitis or compression from tumor infection, MRI is usually the best initial study.
What about imaging for peripheral disorders like GBS or myasthenia?
The article points out diagnosis is mainly clinical and electrodiagnostic, NC-SEMG, but imaging can play a supporting role sometimes. Maybe a cervical spine MRI if there's doubt about GBS versus a cord lesion. And a chest CT is often done in new myasthenia gravis cases to look for a thymoma, a thymus gland tumor associated with MG. Systemic imaging, just abdomen pelvis CT, is also key in trauma for other injuries, or in evaluating CNS masses to find a primary tumor elsewhere.
Beyond structural imaging, the article also emphasizes routine blood work and urine studies.
Absolutely crucial. These labs screen for underlying systemic diseases or abnormalities contributing to the neuroproblem infection. Toxic metabolic issues like electrolytes, liver kidney function, endocrine problems like thyroid or blood sugar. Results are often quick and guide immediate management.
Electroencephalography, EEG, measuring brain electrical activity, has several important uses here too.
Vital tool. EEG monitors patients after prolonged seizures to ensure control, assesses anesthesia depth sometimes, detects non-convulsive seizures or status epilepticus in altered patients.
Non-convulsive seizures are common then.
Yes, the article emphasizes a significant proportion of ICU seizures are non-convulsive, only reliably detected with EEG. It also helps clarify abnormal movements, aids prognostication, and can monitor for complications like vasospasm after subarachnoid hemorrhage.
And continuous EEG is often better.
In critically ill patients, continuous EEG over an extended period is generally preferred over brief routine EEG because it's much more sensitive for intermittent seizure activity or subtle abnormal patterns. Interictal epileptiform discharges abnormal spikes between seizures also provide diagnostic info.
And finally, lumbar puncture, the spinal tap. When is that typically indicated?
A lumbar puncture, collecting cerebrospinal fluid, should be strongly considered in patients with subacute or acute mental status changes or new neurosymptoms, especially if they also have fever, high white count, or other signs suggesting CNS infection like meningitis or encephalitis.
The article gave a case example for that.
Yes, herpes simplex encephalitis, where early LP diagnosis was crucial. LP might also be considered for unexplained seizures or confusion if CNS infection isn't ruled out.
But the article stresses getting a head CT before LP in some cases.
Yes, crucially. If a patient has focal neurosigns like one-sided weakness or decreased consciousness, a head CT should generally be done first.
Why?
To check for signs of significantly increased ICP or a mass lesion that could potentially cause herniation if you do an LP.
But don't delay treatment for infection.
Absolutely not. The article emphasizes if bacterial meningitis is strongly suspected, empiric antibiotics, and maybe antivirals, should not be delayed waiting for the LP. Early treatment is critical, and starting antibiotics doesn't necessarily negate the value of a slightly delayed LP.
Are there other reasons for an LP besides infection?
Yes. If you strongly suspect a ruptured aneurysm but the head CT is negative, an LP can look for red blood cells and xanthochromia, old blood pigment, in the CSF to confirm a subarachnoid hemorrhage. LP is also key in working up suspected Guillain-Barré syndrome, looking for that characteristic high protein, normal cells, cytoimmunologic dissociation, and certain antibodies. And it's used to evaluate other suspected autoimmune, inflammatory, or paraneoplastic CNS processes.
And the article briefly mentions electrodiagnostic studies, nerve conduction studies, MCS, and electromyography, EMG, their role.
These are mainly adjunctive studies for diagnosing peripheral nerve, neuromuscular junction, and muscle problems. They help confirm peripheral neuropathy, distinguish types, demyelinating versus axonal, and support diagnoses like myasthenia gravis.
But maybe not done immediately.
Right, not always available hyperacutely, but the clinical suspicion often arises early from the history and exam, and treatment decisions might need to be made pending the results.
So to bring it all together, this deep dive into the initial evaluation and workup in neurocritical care really highlights an incredibly complex, often very fast-paced process.
Absolutely. It's truly a parallel process of rapid assessment and immediate management. The overarching priority is always first stabilize, then quickly identify those critical must-not-miss conditions needing immediate intervention to prevent further damage and improve outcomes.
It's a delicate, Crucial balance, isn't it?
Hmm.
Getting a focused history, doing a nuanced, tailored neuro exam, considering confounders, and then strategically using diagnostics, imaging, labs, EEG, LP, to get the right diagnosis and start treatment fast.
Exactly. And as this deep dive has shown, it just underscores how critical those initial moments are in a neurological emergency. The immense specialized knowledge, careful observation, critical decision-making that goes into those early assessments to effectively guide care.
It really makes you think, doesn't it? Even in situations that are far less acute, far less dramatic, how important is that systematic, thoughtful approach? Recognizing patterns, considering all potential causes,
Hmm.
certainly give you a whole new appreciation for the intricate diagnostic process in medicine and, well, for the remarkable complexity of our own nervous system.
It does.
Maybe after this discussion, you'll find yourself pondering, the more subtle aches, pains, changes in your own body or those around you a little more deeply. Perhaps you'll even be curious to explore some of the specific neurological emergencies or advanced diagnostic tools we touched upon today in greater detail.